be with you today. This is our 11th, hard to imagine, Pinnacle Lecture series. So I am, in case you don't know, Susan Gennaro, the Dean of the William F. Cannell School of Nursing. We have come together again as a nursing community to listen to an esteemed colleague give us some information and have some dialogue about leadership in nursing, especially moving and changing clinical practice. It is wonderful, through research, which of course we like to change it by. It is wonderful to see so many of you who are old friends and have been here for a number of these. Wonderful to have new people coming. I will just remind you, and you probably all know this, that we are offering contact hours. So they are provided by Boston College, and in order to get them, we needed to have, let people know when you registered. If you haven't registered, at the end of this, you can go back to the desk and make sure that you're signed up, because then you'll be sent an online link to do the evaluation, and that will give you an electronic certificate for your contact hours. And of course, we have no conflict of interest, and we're doing everything all the right way when it comes to CDE. So that's really the business part. We are having a reception following the lectureship, and we hope that you will all be able to stay with us and dialogue and have some discussion about what you're doing in your lives and how this even helps you in all the things that you're doing. So let me, with no further ado, introduce our guest. It is a real pleasure to introduce Margaret Gray, who's the Annie W. Goodrich Professor at Yale School of Nursing and its former dean. Currently, Margaret directs the Translational Research Center for the Yale Center for Clinical Investigation. She was the founding director of the NIH-funded Center for Self and Family Management, and I am happy to say that I was on the advisory. That was nice, right? I also should say, in full disclosure, that for a number of years when I first really was started out in academia, I had the pleasure of having an office not too far from Margaret. And for all those of you who realize we only have 2 weeks left in our Fitbit challenge, and nursing once again is at the top of the leaderboard. So we're all walking around with our Fitbits. I have to walk while I'm doing this. It's not so good. But Margaret was always a leader in health promotion and how to stay healthy and jogging and all those kinds of things. So that's why I mentioned the Fitbit, because she was always out there first before it became such an important part of our lives, or at least my life. Margaret is a pediatric nurse practitioner. Her expertise is in diabetes, and she has spent a lot of her research career in thinking about how to help individuals and families manage chronic conditions. So she's going to share tips with us, leadership tips, for how we advance science and translate that science into practice, and what kind of resources and hurdles we face. So on a personal level and on a professional level, it's such a pleasure for me to welcome Dr. Margaret Gray.
Thank you, Susan. It's really a delight to be here. As some of you know, I'm on sabbatical right now, which is one of the world's great pleasures that I've never had the opportunity to enjoy in 38 years as an academic. And I just returned last week from a 6-week trip to Australia and New Zealand. So the thought of traveling again was a little daunting a week later. But I thought to myself, it's only 2 hours on the train, and it's the same time zone. And I promised Susan I would come, so here I am. And I will not tell stories on Susan unless you bribe me with a glass of wine. We have known each other a very long time, and I think share a love of laughter as well as a passion for our fields of study. And so when she asked me to come, I was delighted to accept. She did have to twist my arm a little bit to make it this week, though, I should say. So I'm going to talk about what's new in self-management science. This is going to be a talk that's really about how a field that we call self-management has evolved over the course of time. And I'm going to illustrate that with pieces of my own research and then talk about what this means for clinical practice, what this means for research, and what this means in the great scheme of population health and things like that. Now, I hope I haven't built this up too much, but I have a great deal of passion for this. I have worked pretty much my entire advanced practice career with children and families with type 1 diabetes, a little more recently with children and families dealing with type 2 diabetes. And, as you know, diabetes is a disease that we as healthcare providers have very little control over. And once we as healthcare providers figured that out a long time ago and realized it's not about us telling them what to do, it's about us enabling people to manage these conditions at home, that we figured out how to do it much better than we've been able to do it. So that's what I'm going to talk about today. I have one caveat. In the last 6 weeks, I have been on 16 different air flights. And you know what happens to people when they fly around, they get viruses. I am really pretty well, but occasionally I get this coughing thing that you all think I'm dying and that I have TB. Just trust me, I will take a drink of water and I will get over it, but I'll apologize now instead of every time I do it. So I have no conflicts of interest. Every time I do this, I like to say, I wish I had conflicts of interest. I would make more money, but I don't. So what I'm going to talk about today is we're going to talk about what is self-family management, talk about where the science is and where it's going, talk to you a little bit about my own program of research and what it tells us about self-management, and then to draw some implications for research as well as for clinical practice. So what is self-management? There are probably 500 different definitions in the literature. I've pulled 3 that I think are the most important. The first is simply a cluster of daily behaviors that individuals perform on their behalf to manage a chronic condition. It is also, as described in the second definition, a dynamic means of maintaining health, rather than submission to the prescribed orders implied by the terms compliance or adherence. We thought we got smart when we changed from compliance to adherence, but it's still all about what we tell them to do as opposed to how they make sense of their own condition. And then Wikipedia, the great definition of the 21st century, tells us that self-care, in terms of health maintenance, is any activity of an individual, family, or community with the intention of improving or restoring health or treating or preventing disease. So it's really this broad concept that gets beyond medication adherence, in the case of diabetes, taking your insulin when you're supposed to, eating what you're supposed to, etc., to really thinking about what an individual's goals are for the management of a condition and what they need to do to be able to be successful. So it's a dynamic, interactive, and daily process in which individuals engage to manage a chronic condition, and it has to do with the ability of the individual in conjunction with the family, the community, and healthcare professionals to manage symptoms, treatments, lifestyle changes, and psychosocial, cultural, and spiritual consequences of those conditions. So we all know, for example, that with conditions like diabetes, a lot of people have concerns with depression, and they have concerns with other kinds of psychosocial consequences. And what we try to do in applying self-management constructs to working with these families is really to help them come up with a way that they become the master and don't rely on healthcare professionals to be the master of their care. So this is a framework that my colleagues and I developed at Yale a while ago, where we talked about factors that put people at risk or protect them from the need to engage in self and family management behaviors. And that self and family management, can you hear me if I'm facing this way?
Yes.
Okay, thank you. Outcomes related to health status, individual outcomes such as quality of life and adherence, family outcomes such as family functioning and lifestyle, and environmental context. Now, this was a relatively complicated model when it was published about 2006, that's 15 or 10 years ago. And I'm here to explain, and part of the early part of this talk is that it's become much more complicated now as we've learned much more about these constructs. So this is a paper that my colleagues and I published just this past the beginning of 2015, where we expanded the model to look at facilitators of self-management and barriers to self-management. And those of you who are interested, these slides will be here. Somebody in Jane Gennaro's office can make them available to you, so don't make yourself crazy trying to see it all. And this all comes out of both synthetic work as well as research that has contributed to this field over the past 12 to 15 years. Importantly, the National Institute of Nursing Research has put a lot of money into the study of self and family management of chronic conditions, and so a lot of these findings come out of those research studies. So, personal and lifestyle facilitators and barriers, health status, resources, environment, and the healthcare system. And what really has changed now is our understanding that the process of what the processes of self-management are. And I'm going to go through these in more detail. And then the other piece is that the proximal outcomes are those behaviors and thinking and biomarkers and symptom management that are immediate outcomes of self-management. So if I learn how to take care of my illness, I may be much more likely to follow and learn more about a prescribed diet and follow that than if I didn't understand why I was doing that. So, and you need to change these behaviors before you get to the further out outcomes that have to do with health status, quality of life and psychosocial status, family outcomes, and utilization of health care. So what are these facilitators and barriers? This comes out of my colleague Dina Shulman's Green work, where this is actually a synthesis of the literature looking at primarily adults with multiple different kinds of chronic illnesses. So we all know that knowledge is, fundamental to behavior change, but it's not sufficient. I've often said, I grew up as a fat child. My weight's fluctuated 30 pounds more times in my life than I can count. But I work with people with diabetes, so I clearly know exactly what I ought to be doing. So if knowledge was all I needed to do, I'd weigh 100 pounds. But there's much more to doing what you have to do when you're managing a chronic condition like obesity or diabetes that have to do with your beliefs, your emotions, your motivations, and your life patterns. In the last 10 years of my life, when I was dean of the School of Nursing and I was eating meals out 3 or 4 nights a week, it became very difficult to manage my weight. Now that I'm out of it, it's a little easier. What people's health status is going into a situation that's chronic illness self-management. What other conditions are there? In the example of adults with diabetes, for example, who have heart disease and hypertension, they get conflicting information about what they should eat. And it makes it very difficult for somebody to figure out what they ought to be doing, what symptoms they have. People with diabetes who have neuropathic foot disorders, you know, we're telling them to go out and walk. Well, they can barely stand up. Yeah, so we need to take all that and then cognitive function in terms of how well they understand what it is we're trying to do. What resources do they have? You know, caring for chronic illnesses like diabetes, people don't think of diabetes as being very complicated, but the cost of doing things like blood glucose testing and these, you know, fancy new insulins that, you know, are DNA generated, or equipment for the management of some conditions can be extremely expensive, and for families on fixed incomes, that's really a problem. You know, what the home or community environment's like, and then what's their access to healthcare? How good are they at navigating the healthcare system? I mean, I don't know about you, but I spent more time as an inpatient in the last 15 years than I would ever like. And I'm an expert in the healthcare delivery system. So every time I'm in there, I try to think about what it's like for somebody who isn't. And I don't know how they do it, to be perfectly frank. So the processes of self-management have to do first, and this tends to be the most, you know, these tend to be, to a certain extent, in chronological order. The first thing you have to do is you have to focus on illness needs. So what do I need to learn? What do I need to know? What things am I going to be responsible for doing? And once you get a handle on that, then you can start activating your social support network, your family, figuring out how you're going to get all these, you know, these pieces to come together. And finally, you come to a place where it's not managing an illness, it's living with it. Incorporating it as part of your identity, making it part of yourself, and figuring out how you balance that. We did some work early in my career. I'm going to show you one slide that came from that study, but one of the things we learned was in kids who are newly diagnosed with type 1 diabetes, initially they have a pretty expected response when it comes to psychosocial symptoms. And what happens over time, in comparison to a group of kids who don't have diabetes, who are age and gender matched, they look pretty much the same until after the 6-month period. And then after the 6-month period, you start to see some discrepancy in these psychosocial symptoms. And when we went back and asked them what was going on, they said to us, this is when we realized that this is really for life. And it's not about the tasks, it's about what I'm going to have to do day in and day out to incorporate this as part of our life. So that becomes a really important piece of self-management that, as you see, is far beyond a simple concept like adherence or compliance. So what's part of focusing on illness needs? Things like acquiring the information, learning the things you need to do, the skills and the strategies you need to use. Taking ownership of those needs, recognizing how your body reacts to those things, and then, you know, helping yourself complete those tasks, feeling good about doing that, and becoming an expert. In all the years I practiced with kids and families with diabetes, when families would say to me, "You're the expert," I would say, "I know a lot about diabetes, but I don't know your child, and I don't know your child's diabetes. You are the expert in that." And it's critically important when you really learn to take on self-management that you acknowledge that I am the expert of my condition. And then making sure you keep up with health promotion activities, changing your behaviors to minimize disease impact, and then sustaining your health promotion activities. You know, Susan says I was an early adopter of exercise. I was an early adopter of exercise because it was the only way I could control my weight for many years. And I would get up and run at 5 o'clock in the morning, which, you know, was fine for a while until I fell and broke my foot. And various other things happened because I tripped over a rock, you know. And, you know, I had to figure out how to do it in a different way. So, but it's figuring out how you get these things into your life in such a way as to manage. by activating resources, I think this is pretty obvious, but it's really, figuring out how you maintain relationships with providers. This is one of those areas where patients really need to be empowered to be a partner with their provider, as opposed to meekly sitting in an exam room saying, yes, do. Because if they sit there and say, yes, I'll do it, without a conversation about how it fits into their life, they're not going to do it with all, most of the time. Identifying their psychological resources, whether they be internal or external, and figuring out how you're going to benefit from those. For people who are spiritual, identifying spiritual resources and sustaining the spiritual self in the context of trying to figure out how you manage these conditions. Social support can be good or not so good, and so it's really important to figure out how you mobilize your social support network to help you. And community, and the same thing in terms of community resources. I do a lot of work with inner city children who are at risk for or have type 2 diabetes, and one of the biggest issues that these kids have is that there's no safe place for them to exercise. And so families will often, work very hard to get their schools open at night so they can, walk in the gym, and they do walking buses, to get to walk kids to school, as ways to get physical activity into their day without having them out on the streets, when it's not safe. And then living with a chronic illness is really about making this illness a part of your identity. Really understanding your emotions about the condition, adjusting to it, adjusting to, I am a person with diabetes as opposed to, I'm a person who doesn't have a chronic condition. Integrating that into your daily life, making it part of your routines and making it part of your normal activities, and then making meaning out of it. I think anybody who gets diagnosed with a serious condition, asks questions about why me, what did this happen to me, but sort of how can you use this experience to be even better than you were before? It's about making meaning. So as I said, in addressing those processes, and we develop self-management interventions to support families, or individuals and families, who have chronic illnesses. We're really interested in developing better outcomes. So these proximal outcomes have to do with helping them adhere to a medication regimen that makes sense, diet, physical activity, sleep, etc., that are critical to well-being in anybody, but in particular in people with chronic conditions, helping them to activate resources. Do they actually, go out and seek the resources they need? We can tell you to go to the YWCA and participate in a diabetes prevention program, but if you don't go and you don't do it, it's not going to be very successful. And then feelings of self-efficacy, self-confidence that I can, in fact, do the things I need to do. I can be successful at this. I'm motivated to take care of myself. And it's really important that we create situations that allow individuals and families to not feel overly stressed by the burdens of these conditions. I mean, one of the things that fascinated me when I first learned about childhood diabetes was what we asked these kids and these families to do was almost incomprehensible. And when I teach students about learning how to take care of kids with diabetes, one of the first things I have them do is we get them some saline and some insulin syringes and a blood glucose monitor, and they have to count carbohydrates for every meal, figure out how much insulin they would take if their blood sugar was something, then inject themselves with the saline as if they had diabetes, think about what they would do if they were going to be physically active. And I will tell you, they do that for 24 hours and they go, how do these people survive? It changes your whole mindset when you're feeling like these people just don't comply with what I want them to do. And that's really, really important to help them. I've recently gotten interested in looking at what the impacts of these self-management interventions are on stress, on inflammation, and gene-environment interactions. I won't tell you that I'm an expert in it, but I've been doing a lot in terms of stress responses because it helps explain to us how our intervention actually reduces hemoglobin A1C in people with diabetes. And then symptom management is a whole new area that the NIH, particularly NIMR, is very interested in. And so there's a whole lot of work starting about what's involved in the self-management of symptoms. You know, most self-management literature is about managing a complex condition or complex conditions. And some of this new work is focusing on symptoms and how people manage those, like sleep disorders and depressive symptoms. So why do we care about this? Well, we care about this because good self-management, positive behaviors, lead to improvements in health status, in the control of conditions, and ultimate morbidity and mortality. They improve individual outcomes such as quality of life and adherence. In conditions like HIV, which is not my field, we know that the level of adherence to drug regimen is highly associated with disease outcomes. And so even though that people don't have to be 100% adherent, they certainly have to be way more adherent than is usually the case. Families are intimately important in the management of chronic conditions. A colleague of mine at the University of California, San Francisco, his name is Kit Chesla, has done really groundbreaking work in understanding how partners, you know, husbands and wives, one of whom have diabetes, figure out how to dance, the dance of who's responsible for what. And as you might imagine, there's mostly women in this room, don't take offense, and that's our data show, that if the man has diabetes, the woman changes the entire family to keep the husband well, or to get the husband well. If the wife has diabetes, she does what the husband wants. These are Chinese American families. She does what the husband wants and sacrifices her own health in service to that. So her work has been to develop interventions to empower these women who have husbands with type 2 diabetes to be able to take care of themselves at the same time they're doing what needs to be done for their husband. And then healthcare outcomes really have to do with utilization of care and enhancing provider relationships. So now I'm going to turn to a little bit about my own research and my own project. So I started out, I've worked in the field of diabetes since 1975. That's a long time ago. Back in those days, we didn't have blood glucose monitoring, we didn't have carb counting, we didn't have all the things we have today, but it was still a tough condition to manage. And back in those days, the emphasis was all on diabetes education. You heard diabetes professionals that they just don't know enough. Well, you know, if you ask them, they know perfectly well. I learned pretty early in my clinical career that, you know, if I was sort of feeling like throwing up my hands with an adolescent, and there were a lot of those times, I'd say to them, excuse me, do you remember we talked about this? Yeah. And what did I say? And they spit it out as if it was on a tape recorder. I said, so clearly I don't need to repeat that whole speech, right? So then I started really understanding about how you got to get at the barriers. What's the issue here? You know, what's getting in the way of taking what you know and applying it? And there are lots of different reasons for that, but if you don't get at those barriers, you're never going to make much progress. And so over the course of time, we've gotten away from the notion that it's all about education or it's all about adherence. It really is about what are the activities of self-management. So those are the classic in diabetes about blood glucose monitoring, taking your insulin on time, carbohydrate counting, etc. What are the processes you have to do? How do you build this into your life? And then what are your goals compared to my goals? I might want your A1C to be 6. But if that's not your goal, we're going to be talking like this all the time. We need to be talking about what's most important to you and how do we set goals that make you happy and push things along the way to make it better. So there's a whole concept in diabetes called diabetes self-management education, which really for many years focused on provision of knowledge. We still do a lot of that in terms of bringing people together in a group and telling them what diabetes is, etc. And then focusing on lifestyle behaviors such as diet, physical activity, and skill development. How do I actually test my blood sugar? How do I read a blood glucose meter? How do I give insulin, etc. But once people master this, then it's clear that more is needed. And this is the piece of self-management that's driven most of my career. So it's really about, my work has been about a program called coping skills training. Others have looked at motivational interviewing. How do you get people excited about doing it? And then adding in pieces of self-management education as time goes on. And finally, where we're moving now with dissemination and implementation science is figuring out how this fits into a system of healthcare that right now is based on single episodic visits with a healthcare provider of some ilk who don't always talk to each other. And how do we make sure that we have a comprehensive approach to self-management and clinical practice? So this is has been the focus of my work really for the last 10 years. And that's development and evaluation of an internet-based approach to improving self-management in teens with type 1 diabetes. Now, I will tell you that as a pediatric nurse practitioner, when I started out, the thought of specializing in teenagers with diabetes was something I would slip my wrist about. But the fact is, after years of practicing, everybody giving me their problem beings to work with, I discovered that anybody who's kids knows that they don't think like humans, they think like teenagers. But what was great about teenagers, if you are completely non-judgmental and you say to a teenager who tells you some boneheaded thing they did, and then you say, tell me what was going on. Tell me. And they'll tell you the whole story, and they'll get halfway through it and go, God, that was stupid. You know? And so, what I've learned over the years is, if they're willing to share this, as long as we don't jump down their throat and say, but you should be doing this, you actually can get somewhere. So we know that diabetes management in teenagers is compromised by simply being an adolescent. Going into puberty raises blood sugar. It makes parents very anxious because then they start asking, what did you eat? They didn't eat anything. Their hormones surged. Their blood sugar went up. We also know that better diabetes control is associated with a reduced risk for long-term complications. There's a big study, the Diabetes Control Complications Trial, findings released in 1993 that said if you more intensively manage diabetes, the lower the hemoglobin A1C, the lower the risk for long-term complications. And a series of studies that we did back when I was at Penn and a little bit later show that primary and secondary control coping is associated with better outcomes. So what do I mean by primary and secondary control coping? Primary control coping really has to do with what you and I think of as problem solving, of actively thinking through a problem and making a decision based on alternatives rather than, you know, sort of just generalized thinking. Like, you know, most of us act on impulse. We don't problem solve, and teenagers are worse than that than anybody else. And in general, teenagers make decisions based on the social situations they're in. They don't want to look like a jerk in front of their friends. Period. End of discussion. Some of you haven't been teenagers, have not been teenagers for not as long as me, and you will remember that. And so, trying to insert into that, I have diabetes, and if I do this, I'm not looking like a jerk in front of my friends. Then they do boneheaded things. So, you know, a classic example is, I go to a party. I'm sorry to tell you, teenagers do drink alcohol, and they feel like they have two choices. One choice is they have to go into this long-winded explanation about how I have diabetes, so I'm not going to drink. You know, let me tell you all about type 1 diabetes, blah, 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 blah. Their friends like, you know, and then they look like a jerk in front of their friends. Or the other option is they just drink like a fish like their friends do, and they're as, you know, crazy at the end of the night as everybody else. But 6 hours later, they have a major hypoglycemic event because they didn't eat, because they thought there were carbs in alcohol. So one of the things we try to do is help people think through, you know, there's more to this than those black or white decisions. And so what else could you do? One of my favorite was one that kids told us was, I get a cup of beer, half full, I carry that cup of beer around with me all night long. Whenever somebody asked me if I did, what a brilliant idea, why didn't I think of that? The kids thought. That's primary control coping. Secondary is managing your emotions, because when your emotions get in your way, you make dumb decisions. I don't know about you, but that's certainly true for me. Sadly, even this many years past the results of the DCCT, which was 1993, 70% of youth today fail to achieve target A1C. So we're not doing this very well yet. And we know that behavioral approaches can be helpful to make better healthcare decisions and better outcomes. So this is the study I was telling you before about these kids who were newly diagnosed compared to a group of age-matched peers, where we followed them from diagnosis. This was way back in the days when everybody was taking only 2 injections of insulin a day. That was a long time ago. And they were followed in 4 different treatment centers. And this is the graph I was telling you about, where you see, you know, there's this period of adjustment. The blue is kids with type 1, and these are their peers. And, you know, there's a difference here, but by 6 months, that's really resolved. And then you see it starts to get better, and then boom, this is depressive symptoms in kids with type 1. What you start to see here is the normal rise in depressive symptoms as kids come into adolescence. It's a well-known phenomenon. But this prevalence rate of high depressive symptoms is nearly 3 times in the kids with diabetes as opposed to kids with heart. And as I said, when we went back, the kids told us this was all about living with. How do I make this a part of my life? And that's when we started looking at coping. And in this study, we found that girls tended to have worse metabolic control than boys. That varies now in studies with intensive treatment regimens. Coping behaviors and psychosocial status tends to be stable over the first year, but worsens in the second year as this realization of it's for life sets in. And importantly, avoidance coping. Sort of basically sitting and saying, tell me what to do and I will just do it. is associated with poor metabolic control and poor quality of life. The reason is because they're not learning how to incorporate this in life. They're trying to follow some remote series of sort of recommendations from a healthcare provider, and it doesn't make sense. So the question was, could we target coping skills? Could we learn how to take, life skills, coping skills, and apply it to the management of diabetes in teenagers? So we adapted a program called Coping Skills Training that actually was developed by social psychologists to help youth avoid drug and alcohol use. And the idea behind it is to increase the sense of mastery and competence by taking these non-constructive coping styles and forming more positive behaviors. And it uses a variety of behavioral and cognitive behavioral approaches, originally in small groups, to teach these coping skills. So the skills we taught were problem solving. So when I'm in a social situation, how do I think through what the alternatives are to solving this question? Social skills, those of you who are parents of teenagers will say, why in heaven's name do you teach assertiveness to teenagers? The fact is, what teenagers do is whine. They say, don't nag me, Mom. Don't do this, don't do that. Excuse me, if you get them to tell you explicitly what they want, you have a much better chance of having a strong conversation about where things are going. I'm not telling you this is easy as a parent either, but it also helps them to negotiate for what they really want. Stress reduction. I wouldn't be a teenager today if my life depended on it. Teenagers are exposed to so many things that we weren't when we were young, and they feel it. They're under a tremendous amount of stress. We know that feeling stressed, not only about diabetes, but about other things in kids' lives, increases their blood sugar, makes their diabetes much harder to control. So really teaching kids positive ways of dealing with stress are critically important. Behavior modification has to do with the tapes you play in your head. When I was younger, I never went into a test thinking I'm going to ace this test. It was always, I'm going to flunk. I never flunked a test in my life. What's making me think I was going to flunk this test? But cognitive behavior modification helps kids, to turn that tape off and say, how realistic is this concern of mine? And then to talk to themselves in a much more positive way. Conflict resolution, any of you who work with teenagers or remember being a teenager yourself, conflict is an intimate part of your life. You can make conflict out of almost any conversation. And so figuring out, how to have win-win conversations with people that result in positive outcomes for all is a foreign concept to most teenagers, and so teaching them to do that is critically important. So this is the conceptual framework we used. It's grown and developed over the years. We started with a much more simple one and developed it here, where these are the pieces that are part of coping skills training today. I'm not going to dwell on this. So our first study was a randomized controlled trial of teenagers with type 1 diabetes, where we compared coping skills training with advanced diabetes education. These were teenagers, most of whom had been diagnosed in childhood. So they were 12 and a half to 20 years of study entry. No other chronic illness and an appropriate grade for age. And I've often said when I give talks that this is the slide that made Mark very famous. So I think what this slide tells you is, so the gray bar is coping skills training group. This was a group that got advanced education. And at the same time, at baseline, the study was started shortly after the findings of the DCCT were released. So everybody got put on an intensified insulin regimen. What's standard diabetes treatment now. and with insulin pumps or multiple daily injections. So you see metabolic control improved over time in both groups, but more in the coping training group than in the experimental group. But in the control group, what you see, despite advanced education here, they started regressing to the mean. Their A1Cs started coming back. Whereas the coping skills training group continued to improve. Now, this is not one of your all-time great A1Cs. I wouldn't write home about it today, but the technology was different when we published these data. But in any case, the key thing here is this is a difference of almost 1 whole point of A1C. Based on the DCCT data, that means if sustained over time, reduction in the risk of long-term complications by 10 to 25%. It's the first time that a non-medical intervention has ever been shown to have that kind of impact. And importantly, quality of life in the CST group improved. It seems upside down, but lower scores mean better quality of life on the scale. Improved and stayed improved compared to the control group, which didn't change at all. And the fact is that, as with most people, but teenagers in particular, vote with their feet. If they don't like something you're doing, they just won't show up. Whereas these kids, 90% of them completed the entire program and stayed in the study to the end of 12 months. So, it has really long-lasting and important impacts. The problem is that we did this in small groups. And it's, so then you have to try to get these kids together. Now, those of you who work with teenagers know that teenagers today are out every night of the week doing something. They have music lessons, and they play sports, and they do this and that. So they're too busy to come to a group. On the other hand, 93% of them access the internet regularly. So we decided we would take the opportunity to translate this intervention to the internet, where they could access it on their own time and their own schedule. We didn't have to worry about getting kids together, but we had a discussion board that was moderated so that kids could talk to each other across time and place. And we developed characters that teens could relate to. And they told us, we developed this in a very patient-centered way, with teenagers telling us what they liked on websites and what they didn't like. And they said, don't make us read a whole bunch. Make it active, make it interactive. So we had streaming videos that enacted coping skills, and then they had to respond to those. So we used a mixed method approach to develop Teen Cope with focus groups of kids and their parents, because we had to make sure that parents would feel comfortable that this was a safe thing for kids to do. We developed a prototype, and we brought the kids in, sat them in front of the computers and let them do it. And we did what's called think aloud interviews, which is basically you sit a research assistant next to them and say, just talk as you go through this, and they did that. And one of the things they told us in the think aloud interviews with the prototypes, where we did the voices in the streaming videos, they said those are grown-ups trying to be kids. You get kids to do the voices. So we did. And then, of course, we did a pilot. So the program is an internet-based coping skills training program. It uses a graphic novel format, which is what the streaming videos were. It includes an asynchronous discussion board. We did a randomized controlled trial comparing it to managing diabetes, which was a web-based diabetes education and problem-solving program in teens, young teens transitioning to adolescence, which is the highest risk time in managing teens with type 1 diabetes. So these are the 2 login screens. This is the Teen Cope login screen. These are the characters that were part of this, what I mean by graphic novels. They look like sort of comic book kids, but they did the acting, and we hired high school kids who were in the high school for performing arts in New Haven to do the voices. They got copies for their portfolios on DVD. And this is Managing Diabetes, which is pretty much an advanced diabetes education program. This is just an example of one of the pages in the stress management section. So they were asking this time before, what kinds of things do you do to manage your stress? So here's what other teams have told us, do these kinds of things. So we've recruited kids from 4 different clinical sites across the country. They had to be diagnosed at least 6 months and had no other major chronic illness. We have 320 kids in the study. About half were male, 10.5% were black, and 19% were Hispanic. Mean duration was about 4.5 years. Average A1C at the start of the study was 8.3%. This fairly well-educated parent group with 53% kids on pumps. The kids found the program to be very acceptable. 88% of kids that we recruited in the study participated and completed at least one session. 78% completed 4 of 5 sessions, more in Teen Cope than Managing Diabetes. And 52% were active participants in the discussion board. We were retaining 78% of subjects to the end of the study. So the primary hypothesis was that teens who did Teen Cope would have better quality of life and hemoglobin A1C than those who just had Managing Diabetes after 12 months. But then we crossed them over and said, whatever program you did for the first 12 months, we want you to do the second program, and doing both programs would be better than just one. So this is the 12-month data. We did not show that our hypothesis was true. There's really no differences between these two groups after 12 months. Similarly for quality of life. But what happens after 12 months is in A1C, people who did one program at the end of the 12 months, their A1C started to creep up. Now this isn't as significant a difference, but it is statistically significant and clinically significant. Whereas the kids who did both programs, they started to creep up by 12 months, and then they started to go back down again. And similarly in terms of quality of life. So we concluded, obviously, that doing both is critically important. You can't just do focus-based training, you have to do both. So this program cost us about $350,000 to develop. Now, that seems like a lot. In today's world where internet programs and apps are so much cheaper to develop, you hire college students, they can do it, for $400. Really scary. Maintenance of the program is primarily for the salary of the person who had to monitor the website. Really critically important when you're dealing with teenagers to monitor it, not only for, spreading bad factual information about diabetes, but also there were kids who gave their email address out and, said, can we get together? And, we had to deal with that. But with the differences in A1C, we have the potential to reduce long-term complications by 10%, and the potential for healthcare cost savings due to prevention of complications of over $1 million. So what we're doing now, and just finishing this up, we had funding from the American Diabetes Association to look at the next step, which is how do you roll this out in pediatric diabetes clinics? So if a provider prescribed going to Teens Connect, which is our combined program now, would people do it? Without all the prompts that you do as part of, a very controlled randomized clinical trial. And this is what the Teens Connect type site looks like. We had trivia questions that were competitions, badges for getting answers right. The competition, so you see we had a competition with 3 boys and girls, and Children's Hospital of Philadelphia and Yale, there were the 2 sites that participated. Girls did better, by the way. So it was a randomized controlled trial, and our comparison group was Planet D, which is a website that's run by the American Diabetes Association for kids with diabetes. Tends to be exactly what kids don't like, in that it's a lot of reading. And, but they use it for social networking. It's a way for them to meet other kids with type 1 diabetes. Mixed method study where we looked at not only outcomes, but components of the REAIM framework and cost effectiveness. And this was an early exploratory study with 120 kids. Ended up with 123, same age group, similar demographics, hemoglobin A1C a little bit lower than in the original study, but about the same. The REAIM framework is about what we're doing now in terms of dissemination and implementation science to say, what happens when you have these interventions and you roll them out into the real world? What happens? What's the participation rate? Does it work the same way it worked in the randomized trial? Do people want to adopt it when the study's finished? How closely is the intervention adhering to what it was designed to be? And then how much is it institutionalized? So we found that 78% of those who were approached were randomized, which was much better than in our in-person studies, and 100% of the providers were participating. There were no differences in outcome between Teens Connect and Planet D, which is sort of makes you wonder. But all sites who approached agreed to participate. And they really liked this idea, this provider prescription. The providers felt engaged in it in a way that they hadn't with any of the other stuff. And because the program is online, it allowed us to have good internet or intervention fidelity to the original intervention. We were unable to determine whether maintenance, which is where we're going next, happened in this particular study. So what have I learned? What has my team learned about self-management in this group of people? Really, really important to engage people with the condition in the development of any self-management program. It's really important to help them focus on illness needs as well as living with a chronic illness, helping them to understand it's not about doing what we tell them to do, but it's about helping them figure out how they do it. And those needs may change over time. So what are the next steps in the science? Now this is my musing. I'm well aware that 2 days ago, Nursing Outlook published a paper from Pat Grady and colleagues about what they think are the next steps in the science, but I didn't want to change the slides. So. But a lot of this is in here. Clarifying the biobehavioral mediators and moderators, what facilitates people making these changes, how do they work? Trying to understand more about the self-management of symptoms, not only whole conditions. I think a real key element is this whole issue of dissemination and implementation and being able to develop not necessarily the perfect efficacious intervention, but ones that are sustainable and doable in the context of real life. And to do that, it's going to take translational research methods such as pragmatic and longitudinal trials, comparative effectiveness trials, and cost effectiveness trials. And we in nursing, embraced the all-minor randomized clinical trial a long time ago because everybody says that's the state of the science. It is the state of the science to determine efficacy, but it doesn't change the world. And what we're about as nurses is changing the world and making the world a better place for people. So we need to embrace these new methods and grow with them. As I said, I've gotten increasingly fascinated with looking at biobehavioral mediators. If I were younger, I'd go to a genetics fellowship, but I'm too old now, so I'm hanging with stress biomarkers. But things like genetics, gene-environment interactions, so neuroprocessing, how do people with chronic diseases process all this information and apply it? And then how do the psychological factors impact on those things? And these may help us come to new approaches for tailoring interventions. So rather than everybody needs the same preventive intervention like Teens Connect, can we tailor it much more specifically to what an individual and family's needs are? I'm really committed to the notion of sustainable interventions. How can they be adopted in clinical settings? They need to be cost-effective, efficient. How do we use monitoring devices, point-of-care devices, and engage patients and clinicians in developing these kinds of programs? And they're going to look very different from, the sort of classic, you come into my office and we do this together, I think, going forward. The chronic care model, as you may know, has self-management support as a key element. And a lot of places are moving primary care systems into this kind of a model. But how this is done in the context of all of this and 15-minute or less visits becomes very complicated and requires a lot of thinking. I talked about these new methods or approaches. I met with a young faculty member here earlier in the day and steered her to my new Bible, which is a book called Dissemination and Implementation, Science and Health, which I've learned all new things from. It's been great. It goes to show you that at 66 years old, you can, in fact, teach old dogs new tricks. So before I call so what do I want you to take away? Self-management is not a simple question of adherence. It has many different components. It's really important to address individual and caregiver factors that influence behavior change that needs to be made. This is a science that is moving very quickly, and there's a lot of work to be done. I think as we move toward building sustainability, nursing has a chance to have a huge impact, not only on healthcare delivery, but also on people's lives. And I think these interventions have the potential to really transform population health. I mean, let's face it, chronic diseases are the major causes of morbidity and mortality in this country. Most of the time we know what to do. We just have to help people do it. So I want to thank you for your attention.